I think I've got a question for one of, at least for each of them. Is that okay?
Absolutely.
Okay. My name is Shauna Palmer. I practice in West Columbia, British Columbia. So thank you for coming up and sharing your information with us. I asked this privately to Dr. Echeverria, but I thought I might as well ask it out so everybody else might be wondering. The children that were in the study, did the mercury, was it because of mercury in their fillings, or was it mercury because of their exposure environmentally?
No, this was an 8-year trial, a clinical trial funded by the National Institute of Health. There were 2 of them in parallel, one of them in the US and the other one that I was affiliated is in Portugal. And these children naturally received treatment. And that's how we followed. When they got treatment, we measured their urinary levels. So it was definitely from a mountain placement. Yeah.
And Dr. Yantansi, she's not here, is that correct?
Let's stick to stick on.
For Dr. Haley,
Stick to.
question. I was just wondering out loud, if the FDA or Health Canada or whatever body governing by worldwide, if they approved chelation with the DMVS and DMSA, why is it so difficult to get these other chelating, I guess in quotation, agents passed?
Those chelators haven't gone through FDA scrutiny at all. They were grandfathered in because they were made by the Germans and the Russians in World War II.
Okay.
And so they don't have to do, well, we have to do it. And it's amazing that they can sell that and use that with no treatment, and it's very toxic, incredibly toxic. As a matter of fact, they've killed people with them. And yet, if you go through and you show, like we have with the phase 1, that we're totally without any toxicity and much more effective, you still have to go through the new procedure.
Okay, so you're just waiting for finalization of your trials before you can get approval, is that correct?
Well, we got caught in a catch-22. The EMA and the FDA say there are no mercury toxic people in the United States and Europe. And so how do you do an efficacy trial on a population where there's nobody that's mercury toxic? I mean, they identify what's toxic. They don't consider what most people here would consider toxic as toxic. And so we found this group in in Colombia that are definitely mercury toxic, and that's going to allow us to do probably a pivotal phase 2 study so we can present it to the FDA and everybody else and hopefully get
Approval
approved.
Locally.
Yeah.
If not, we'll have to smuggle it from Colombia, just like everything else.
Well, you have to smuggle from somewhere.
Okay. Dr. Vega, just a second here. Did you, I missed the very first part of your lecture, when you're going through your therapies, are you also doing a lot of diet changes for them as well?
Yes. There wasn't a lot of time to talk about that, but I tell them to check their pH before each meal.
Yeah, I caught that.
And then make the correlation, see where they're at first. What foods are contributing to acidity, which ones to alkalinity, and other factors in their life. And then go from there to decide what to eat, what not to eat.
So you left that up to them, or did you give them a more concise
I cannot give him a concise. That's what we do as practitioners. We tend to give him a list of what to eat, what not to eat.
Yeah.
But I don't do that.
Okay.
I want them to figure it out on their own on those 2 weeks, and it's a very positive experience for them. And then with things to do and what things not to do.
Okay. Thank you.
You're welcome.
Another question. And the electromagnetic treatment, that's something that could we use that as practitioners, or we'd have to go through specific training if we wanted to use it for, let's say, maybe even muscle pain or anything like that? Has that been tested in that area?
You probably can do it, but you have to check the laws of your state,
Okay.
number one. And number two, there's training by the company.
Okay. think I already talked to Dr. Kidd in private, so we got that one done. And the last one for, where am I at? Oh, Dr. Campbell. So you said the genus, Bacillus genus species are spore forming, but not lactobacillus specifically.
Lactobacilli and Bifidobacterium do not form spores.
So it's just certain Bacillus species.
So Bacillus species do form spores.
Okay, so I'm confused. I'm just thinking that lactobacillus is part of the Bacillus group. It's not. Okay.
No, they're microbes, but they're not the
Okay.
same family.
Okay. And we have to, I guess, find out on our own which companies.
Homework.
Homework, yeah. Okay, thank you.
If you want, you can come up and ask me what I take, and I'll tell you.
Dr. Marshall Vega, a few years ago we were told that mercury should be removed from the mouth prior to EDTA chelation because EDTA can chelate mercury into the brain. Comment?
Actually, we have a protocol with intravenous vitamin C before the removal of amalgams. And now that we are going to start setting up the dentists in Puerto Rico to do the protocols that are being done here, that could be done more systematically. But we tend to do the vitamin C first.
Thank you.
There was the mention of the Portugal experiment on the orphans, and that I believe they're now, thank you very much for that talk, I think there are now 3 studies, the Geyers and Woods, showing the boys were impaired in 5 domains if they were CPOX4, and the Geyers showed kidney biomarkers going up with in a dose-dependent fashion. The NIH requires that if an injury occurs during an experiment, that those injuries be treated and ceased, stopped, prevented, or treated. Are you aware of any of the people involved in that who have taken any steps to treat those injuries?
I only worked on the Portugal one, okay?
That is Portugal.
Yeah, and that was my study too, by the way.
I understand.
And what I did is subsequent to the end of the trial, I inherited that data, wrote a new grant with Jim Woods, and we reevaluated the data. Okay, so I wasn't actually involved in the data collection piece of it or in the design. I only collected the genes and added genes to the neurobehavioral effort, okay? So the last 14 papers that are part of that study are in fact a separate grant from the first round. As far as harm goes, I have not actually heard of anyone following up based on harm. I have not heard that. And I think we went back to Portugal to collect extra genes just from a swab, right? And we heard no adverse events that were beyond what, you know, the initial pilot had done. So I don't actually recognize whether any scientist involved or NIH-funded individual involved followed up in that manner.
Thank you.
Okay.
I want to let you know that we really appreciate all your expertise and education. I really appreciate people who teach. But a question for Dr. Haley. Do you have any timeline when you think the NBMI is going to be available to the public, and speculate?
The timeline depends upon how fast the regulators respond and do things. And I've had enough experience with them that I wouldn't make any prediction. But it seems like it'll be next year sometime. I mean, it should be. I mean, we'll have the studies done by then, but I don't know what they'll do.
Great.
Maybe next year.
Well, I'm pretty sure.
Yeah, great.
Yeah.
So I have a question for Dr. Haley also. I know you said that bound mercury and BMI compound stays a long time in the body. Do you have any idea of how long it is?
Well, yeah, we've followed it. We've trapped it in the body, and it leaves almost 90% of it over in 60 days. It's gone.
60
It just goes out slow.
Awesome. And is
And that's from the liver, the brain, and all the tissues we've looked at. It leaves, but it's slow leaving, but there's no toxicity associated with it when it's still in there.
And does it go out through the stool? Through the stools, the feces? Is that how it gets out?
Yes, it is almost totally eliminated through the feces, not through the urine at all.
Thank you.
Question for Dr. Echeverria. Thank you for all your information this morning. There's a lot there to unpack, but your name wasn't on the bio as far as on the speaker list, but just a question, the research was sponsored by, who sponsored the research?
Which one?
Well, most of your research.
About 110% are funded by 6 grants that were written independently over 25 years.
6 grants from?
Yes, from NIH, the National Institute of Health.
So our own government is
Yeah.
finally admitting that mercury is, well, of course I know they admit it's toxic, but they're not really admitting it's toxic in the mouth yet.
Well, no, you must distinguish a regulator from a research organization. So NIEHS is independent of any regulatory body, including ones that enforce law, right? And they don't take that position as researchers. That isn't true, all right? But the problem is once you generate the evidence, what are you going to do with it? So they'll generate the evidence, but they won't necessarily take action on it, right? That's our job as advocates.
All right, thank you.
I had 2 questions. First of all, thank you to all the speakers for a great day. One question for Dr. Marcio Vega. With the calcium EDTA push, the IV push, I understood from your last time you were with us a few years ago that that was really helpful for getting rid of the metals more than the drip. Is it also, I think from what I've heard today, that it's also more advantageous for just cardioprotective as well?
We have found it's more effective across the board for everything we've looked at.
Great.
So we don't use the 3-hour anymore. Yeah.
For anything, okay. That's what I thought I got, yeah.
Thank you.
Thank you.
And it's cheaper for the patient, more cost effective, less time requirements.
Yeah. You don't get to read as many books that way, but that's okay. One question also for Dr. Campbell. If some of us who take probiotics by eating fermented vegetables like raw sauerkraut and that kind of thing, as well as supplemental forms of probiotics, can you give me an idea of the time, like if you eat, let's say, raw sauerkraut, for example, or yogurt that's got real stuff in it, when it gets through whatever survives the gastric passage, how long does it take for the spores that would form, I guess, in the stomach to then re-energize and become viable in the colon? And you get the...
Are you talking about foods?
Foods, yes.
Okay. There has not been any studies made on foods. It's very hard to do that because it depends on when it was grown, where was it grown, the type of earth, what is in that earth, is there more of this mineral or that mineral? So it makes it very, very difficult to, and then you've got to find, I don't know, 50 or 100 people who are the same age, same height, same weight, but who also have similar lifestyles. And it just makes it for any foods, it makes it kind of difficult to, unless you go to a university and do it with students, which is what a lot of people have done, but not, unfortunately, in the foods, such as the foods that have been used for millenniums,
right,
now, such as the sauerkraut and the kimchi and etc.
So
we don't know.
Well, that's a fair enough answer. The same question then with the spore-based supplement or form. Do you know how long they take to become viable? In other words, leave the spore form into a viable
measurable effect, meaning you can measure it in blood.
Okay.
Such as, did it lower hemoglobin A1C, and did it lower blood sugar, did it lower triglycerides, did it lower rheumatoid factor, et cetera. 6 weeks is when it starts doing that.
6 weeks, okay.
That's what the studies show.
Okay, thanks.
Thank you very much for everybody's amazing information, and in behalf of all the dentists here, I want to speak to Dr. Haley about this fabulous medication that you're creating. So a lot of us, like I have been practicing for 30 years, you know, is of urgency that we received your medication because of the consequences of mercury in our lives. So I'm sure a lot of dentists here are very excited about what you're doing. So I went on the internet and I was looking into, you know, emeramide, and I know that there's German doctors that you can go and get a prescription. So if a group of dentists went to Germany and got treated with that, would that be a possibility to help you in the research that you're doing? Because, you know, there are so many dentists that are interested in getting the medication from you.
The one thing I can tell you is that each country in Europe has a different status on this. Every country, I mean, I can go to New Zealand and get it right now. And Germany, it's left up to the individual doctor to write prescriptions without any government involvement. In the United States, it's just the opposite. So it's too complex. You have to, I don't know the best way. I mean, call Donald Trump, I guess. I mean, I don't know how you can get it to go any faster. I mean, if I could do it, I would do it. I
know.
Yeah.
I figure we are, I don't know how many people are in this organization, you know, maybe 1,000 dentists, I don't know. So I would think that, you know, there's a lot of power in the amount of dentists that are part of this organization.
Well, yes, I think anytime you have a social action by a group of educated people, you get some attention. The government hates publicity, especially if it's negative. So, but I don't know the best way to tell you to do that. I know if I do it, I get in big trouble. I mean, it's called promoting a drug off-label, and I'm not going to do that.
Yeah, okay. And you're a dentist in Puerto Rico? No, the...
Radiation oncologist, medical doctor.
Okay, very good. Very good. Thank you.
You're welcome. Yes.
Dr. Campbell,
Got a couple of kids, though.
are you able to share with us what you personally take as a probiotic? Sorry. What you take personally as a probiotic?
Well, I don't think me telling an entire audience is the proper thing to do to remain within CME guidelines, et cetera, et cetera. So if you want to come up to me as an individual to another individual, I'll be happy to tell you. However, I will not do so as a group because it would be improper for me to do that.
Thank you very much.
This is a question for Dr. Kidd. You alluded earlier to lesions from nutritional deficiencies, vitamins. Do you have any kind of leads to protocols or things we can do? Like, this is new to me. I wouldn't want to interfere with like a medical doctor or naturopathic doctor in what they do. But if I see these lesions, you know, like, what do you recommend we do, basically?
Sorry, what kind of lesions?
You alluded to vitamin K, K2, but a couple of other vitamins that you could tell. I think you mentioned vitamin C, folate, yeah, the different ones like that.
How do I identify?
No, we saw the pictures, you know, but if I see that in my office, you know, what do you recommend we do, basically? You know, like
well, you're speaking as a dentist.
Yeah.
I don't think there's any limitation of advice you could give nutritionally.
I don't see that's something you need to hand over to a physician. You'd be hard pressed to find one. Really, a lot of the nutritional repairs that are being done now are being done by patients who are self-educating. You know, it's amazing. I have a consulting practice, and I get people with very, very complicated problems. And they've seen many specialists, and they come in with a thick layer of stuff they got from the internet. And they say, I've seen 12 doctors, and they don't know what I have. But I think I have this. And they're usually right. So I think the lines that we've drawn around the professions are starting to have less and less meaning. There are certain laws there, of course, but 30, 40 years ago, all our knowledge was in libraries, medical libraries, and nobody had access to that but MDs. Now that information is totally available to the public, and many of them are quite expert in nutritional things. So I wouldn't hesitate to let the patients do a little bit of work on their own. You can get training in it. I mentioned Alan Gaby's book. It's a $200 or $300 book, but it's amazing the way it's laid out, because it has sections. It'll have a whole couple of pages on vitamin A, you know, where it's from and what, you know, the foods you can find it in. But then it also has sections on, say, periodontal disease and all the nutritional things that relate to it, or any medical condition you can think of. It's there. So you could use that as a resource. It's a simple way of doing it without spending too much time on the internet. But
could you? What's the name of that book again?
Alan Gaby's book. I think it's called Nutritional Medicine.
Okay.
Am I answering your question?
Yeah, that's perfect.
Yeah. Okay.
Yeah.
Thanks.
Thank you.
Guess this is for probably Dr. Haley. We heard a presentation on PDX, which I wasn't familiar with before, as a new detox drug apparently, and you know, I'd just be curious to know what reaction you have to that. I mean, it doesn't move into the cells of the body the same way that NBMI does. And maybe you could comment some more on the differences. I mean, what's the contrast between NBMI? Obviously they're different, NBMI and what you saw, if you saw that lecture that most of us saw on PDX.
I guess I didn't see the lecture you saw. What was the other chelator? I know I've read a lot of literature on chelation.
I don't know if I can do it justice, but it's some kind of a drug that is moves into the GI tract and stays within the GI tract. It can't be absorbed, so it's not a nutritional thing. It's some kind of a chelator, and it has a thiol on it. So she called it thiol-SAMMS. MMS. And that's an acronym, but I mean the thiol part, you know, it's sort of like acting like glutathione, but apparently over time it binds and binds and binds and helps reduce mercury in the body, and but it doesn't move into the whole body the way.
I now know what you're talking. I now know what you're talking about.
Okay.
You know, it's something that would be very effective for cleaning mercury up in your diet. But you see, if you're a dentist and you're breathing mercury vapor, the mercury doesn't go through your intestine before it gets in your brain, so it doesn't help when you're doing a volatile or getting it from another source. Also, most people that are pre-toxic, I mean, if you've been around, if you look at the NHANES data, you know, the amount of mercury in our body goes up dramatically after we pass 18 years of age. And so you've got to go in there and get it out. It's inside the cell. And that's the reason NBMI is so effective, is it crosses. I mean, for example, when Dr. Echeverria talked about the pre-pro-coporphin, when I first started preparing this compound, I had people tested that had showed they were mercury toxic by the research done with her and her colleagues, showing that, you know, the pre-coporphin, easy for me to say, was elevated. And when they would take NBMI, it would go down to normal. And so that tells you that NBMI gets inside the mitochondria, and the enzyme that's blocked by mercury to elevate that pre-coporphin is on the outer aspect of the inner mitochondrial membrane. So it says that NBMI gets inside the first membrane layer. If it's in your gut, it can do good things, but it doesn't detoxify somebody.
At the meeting in Savannah, you drew a contrast between DMPS and DMSA as chelators. Basically, you said they weren't real chelators, and NBMI, which is a real chelator. And I think it's good for you to say that contrast, and I think it really raises questions about, I mean, there's some doctors who just totally rely on DMPS and DMSA, and I tell people that's back from the 1990s. We have better things today. So just comment on that contrast, if you would.
Okay. The fact is DMSA and DMPS are called chelators, and they're not. They form sandwich complexes, and the chemistry is that if you look at two big thiol groups on adjacent carbon atoms, there's not enough room between those two thiol groups for a mercury atom to bind. And so they form a sandwich complex, so they're not they're not chelators. And when you only have one sulfur bond to a mercury atom, it's easy to exchange. That's the reason they can pick up mercury out of the blood, carry it into the kidney, and drop it off to the more reactive thiol groups in the kidney, and they can cause renal problems by building up the mercury in the kidney. And NBMI, when I started designing it and those compounds and putting it together, I decided I was going to make a compound that could form chelates. I mean, that's two atoms bound to it or more, to a single atom of mercury or cadmium or whatever. And so we gave it what we call degrees of freedom of rotation and movement, such that it can bind any cation that has attraction to sulfur will be chelated by NBMI. And that's turned out to be true. And it binds with incredibly high affinity. I mean, we can't measure the KD because it precipitates out and it won't dissolve. So.
Does the same apply to alpha lipoic acid?
Alpha lipoic acid would have enough room to form a chelate, yes.
Oh, so it's better than DMSA? Is that?
If I had my choice to take between the two, I'd take alpha lipoic acid. The problem you have with alpha lipoic acid, and one of the things that I designed in the compound, you don't want anything that interferes with a metabolic system. Alpha lipoic acid is the substrate for pyruvate dehydrogenase complex, and if you put it there, too much of it, you cause problems. And you can actually carry mercury into a cell with alpha lipoic acid. I mean, that would be if you want to get mercury inside a cell, and that's on the inner aspects, and then mitochondria, of course. So there's a concern there.
Dr. Haley, what dosage are you normally using for your studies for the NBMI?
We do everything from 50 micrograms per day up to 1,200.
Okay.
And mainly they're safety studies. And on the rats, we've gone up very high, just trying to find out. The thing you do, the compound is very readily absorbed. About 60 to 80% ends up in the blood. And so if you do a calculation, after you measure the amount that's in the plasma by experiments, we can tell you that if you take 300 milligrams a day, you have 45 atoms, roughly, of NBMI or chelator for every atom of mercury if you are somebody that's really very mercury toxic. So you don't have to take a lot of it.
Okay. Are you going to have like a recommended dosage once it comes to market?
We have to have.
Mm-hmm.
They make us.
So are you know, like...
Yeah, it's not toxic, so it's easy to do.
Like 100 or 300 micrograms or something like that?
Well, some of the problem you have is when you looked at the Ecuadorian miner study, the 100 milligrams per day did not have near the one-third the effect.
Is it micrograms or milligrams?
Milligrams per patient. It didn't have one-third the effect of the 300 milligram, and that's because, as I talked in the thing, the compound is a very potent antioxidant. It gets destroyed by reacting with the superoxide the hydroxy radicals, and when it does that, it won't bind mercury.
Okay.
And so you lose it. So when you have to give enough to override the oxidative stress that the patient has, and then have a little bit more to do the mercury binding.
So a lot of it depends on the status of the patient.
Absolutely, absolutely. And that's where good doctors come in. I mean, this is not a cure-all for everything. You have to have good medicine.
Thank you.
Mm-hmm.
Okay, so for a dentist who's been working over 25 years, how long would you have to take when it's available in the United States in order to clear us of the mercury?
Well, I would say in 2 weeks you're going to chelate all the mercury in your body. I mean, that would be overkill, actually. But the thing is, it does not repair the damage. NBMI just stops the toxicity. It does not repair the neurons or the damage of the tissue it's done, and it takes a longer time to do that.
So
and that's where the second aspect of the compound, it's a tremendous antioxidant.
So you keep taking it as an antioxidant to prevent?
It's cheap and easy, yes, I would recommend that.
Okay, thank you.
Did you say how and when we can get hold of the NBMI?
In the bathroom then? Yeah, I guess I was.
No, I can't say. I mean, it's up to the regulators.
I must have missed that one.
Next year sometime.
And that's not an uncommon phone call for me to get. And everybody that calls me seems to think that I'm hoarding it and just want to see people suffer and not give it to them. And that's not true at all.
So, meanwhile, for those of us who are mercury toxic, should we be using DMSA and ALA?
I wouldn't.
You wouldn't?
No. I would use vitamin C. Dr. Tom Levy gave you the best way of doing it. And you know, the increase in high levels of vitamin C cause a production of intracellular NADH and cause the recovery of oxidized glutathione. And if you're mercury toxic, naturally you take glutathione out with no chelators by forming a sandwich complex with glutathione. And so what you want to do is keep your reduced glutathione levels as high as possible. And the best way to do that intracellularly is to take vitamin C.
What kind of level?
You know, I haven't any expertise in that, but I mean, I know I've taken 50 grams IV one time and it didn't bother me, so I don't know that you could underdo it. It's a mass action type thing.
So, oral vitamin C, would that work, or does it have to be IV?
Well, I think they all work, but some work better than others. I think the IV does a lot better. Yeah, I mean, but that's just my opinion. I have no...
There's 2 vitamin C's I recommend by mouth. Vitality C and Live On. Live On, they had a booth here.
Live On?
And the key to taking a lot without needing an IV is to do a lot of frequent doses during the day. For example, I take 2,000 to 3,000 milligrams every 2 to 3 hours. And then I had to travel like 9 hours to get here. I got here at 1 in the morning, Wednesday night. I wasn't tired, and I slept well. And it's because of the vitamin C. I took yesterday about 18,000 milligrams, but I have to do it in divided doses.
So
Otherwise, it doesn't work.
So 2,000 to 3,000 milligrams 3 times a day, or
Every 2-3 hours.
or every 2-3 hours
When you travel.
when you travel?
It depends on your needs. If you have a cold, if you're developing the flu, you can take 1,000 to 2,000 every half hour. It depends what's happening in your life. Your needs can go up if you're really sick. Your baseline need is lower if you're healthy.
So
and intravenous, I start people in 20,000, then I go to 40,000, then I go to 60,000, 60 grams, then I keep going up stepwise. They have to eat before they do it. That's very important. Always have to eat because it will lower your blood sugar.
The issue between IV and oral is you can give much more orally. IV than you can give orally. If you give it orally, you're limited by your GI tract. And the way the GI tract reacts to every person's limit is when you suddenly get diarrhea. Then you have to back down a little bit. Then you know that that's the dose that you can take. But again, 2 to 3 grams several times a day. When IV, you can take 10 times that without any problems. So IV is a better route.
If you're going to be taking vitamin C as a maintenance dose, if you're healthy, not sick, at what level would you recommend?
It depends. You're going to follow your pH. I tell people to do their pH 3 times a day. There's no other way around that. And you can also use a monitor of vitamin C for the urine. But I'd rather use the pH because it's the ultimate goal that you want. You want to have your saliva alkaline, not acid, ever. So if you start taking the vitamin C and your pH starts getting alkaline, that's what you want. That's what you're going to monitor.
Okay.
And frequency. Remember, if you cannot do it IV, because you cannot do it IV today, do many frequent smaller doses. Instead of taking 5,000 milligrams in one shot, I wouldn't do that. I would do it 1,000, maybe 2 hours later, another 1,000, and so forth.
Thank you.
You're welcome.
Dr. Haley, back to the MBNI. You said it was available in New Zealand?
Every country has different rules. Look, the compound has passed all the animal testing, the mutagenic testing, and it's done a phase 1 on students in Sweden.
I understand.
And so it's proved. I mean, the EMA, we've got that far, and you can. Every country has different rules.
No, I get it. I'm just saying about New Zealand. You said you can go there and buy it off the shelf.
No.
No. Because I have patients with the wherewithal that will travel to New Zealand and pick it up if they could do that.
Well, if you contact a doctor and tell him he can write your prescription and you can go get it from the drugstore, I think. I mean, I'm not sure.
In New Zealand?
Yeah.
Yeah. Okay.
Yeah.
Thank you.
Yeah.
Is there any value to alkaline water? Whoever.
That's a good question.
Who are you asking? I don't know. I don't even know what it is. I don't even know what it is, Ron.
High pH water, like 9.5.
Well, let me tell you what I have in my house and in my clinic. I looked at many of the filters, and I have an alkalinizer in the office, and I have another one at home. And with the kids, all the formulas that I prepare over the years were with that water. So it's safe, it's effective. At least it purifies it. The filter purifies it. Now, just giving alkalinity to your body doesn't necessarily make you alkaline. I use it as a filter to filter nasty stuff out. What makes you alkaline sometimes is taking out the acidity, like mercury and all these bad actors. So I'm not thinking of giving people alkalinity, rather taking away what's producing the acidity.
Good answer.
What form of vitamin C do you give IV? Is it ascorbic acid or sodium ascorbate or something else?
So ascorbic acid and sodium ascorbate.
You do use both?
Yes.
And when do you use
I haven't
the
found
other?
a difference, but
Doesn't matter?
I get the ones that are less expensive.
Okay.
And give me the exact same result, because I've been doing it for 24 years, and I looked at different types, but the market is changing also in the different compounding pharmacies. Sometimes you don't get it in one, so you have to have a few available to get it from the other one when these don't produce it for a month or two. So there's a lot of problems in the production of those.
Okay. And so ascorbic acid wouldn't make somebody more acidic than sodium ascorbate?
No, because it's an acid. We're not beakers. You can get an acid in your body and become alkaline, because that acid is killing a bacteria or a virus that was making you acidic. So you see, the net effect is alkalinity.
Okay. Thank you.
Since we're on vitamin C, Dr. Kidd, you said Royal Lee said, you know what I'm about to ask, right? Vitamin C out of a berry versus ascorbic acid that's synthesized or derived from corn. What's the difference? What should we think about that?
I'm sorry, I really can't answer those questions. Royal Lee, I know of his work, and I know people who really respect his work, but he has volumes and volumes. A little bit like Melvin Page. You can't find anything on the internet about him. You have to go to Price Pottinger Foundation, and you can get all Melvin Page's work in binders. That's the only way of knowing about it. And it's wonderful stuff. Excellent, beautifully documented stuff. But to maybe get out of that question a little bit, I really don't know if it is more effective than pharmacological vitamins. But in answering the question about different forms of vitamin C, I always keep some intravenous beet origin, and there's one other, because there are people who do react to the corn-based vitamin C. I think it's good to have it around.
So the corn-based vitamin C is not pure ascorbic acid, it might have contaminants?
No, it's the people have an allergic reaction to it. People just don't tolerate the corn-based. It's a fairly common food sensitivity. Our most common gluten and wheat and dairy and so on, but corn is right up there with soy. And so these very oversensitive people, it's good to use a beet one. There's another one I have, but I've forgotten what its origin is.
So why does it matter what the origin is? Ascorbic acid should be ascorbic acid. What remnants of corn are still in there?
It'll affect some people. Yeah. And it
GMO corn in the United States than GMO beets. So that's why the GMO beets became very popular. In my clinic, it's all non-corn vitamin C, because of the prevalence of GMO in the corn-based
They can't hear that.
Oh, sorry. Yeah.
It's not so much the corn, it's what's in the corn. So there's been a rampant use of GMOs in corn in the United States, plus glyphosate. We think it's the glyphosate, not necessarily the corn. So we in the last 20 years, we've gotten away from the corn, and in my clinic, I only treat with non-corn-based vitamin C. Because with beets and other non-corns, there's less of a chance of having a GMO. There's no business for the companies to make GMO there yet. We hope it doesn't happen.
Okay, this is for whoever would like to take it. Maybe several of you may. My idea was just to ask, given that most people, when they become sick, have a higher sympathetic tone, which we all know doesn't really sort of promote their wellness. Is there anything that you guys know of that you use maybe to help promote the parasympathetic tone, to help sort of balance that autonomics? And what would that be that you would suggest they could add to their repertoire to
Be still
increase their
15 minutes a day, twice a day.
Be still meditation?
Be still. Just be still.
Yeah, there's many ways. Being still, certainly doing all those healthy things that we should do. good osteopathic treatment and neurotherapy can help reduce sympathetic hyperstimulation. When I'm doing neurotherapy, I look for interference fields, and what you do is you find an indicator muscle, find their strength, and if you touch an interference field that's active, there's going to be a sympathetic response, and the muscle strength will change. But you have to have the patient down at a more parasympathetic level for that to work. In other words, there's too much noise. And there are manual techniques which will bring them right down and make them... what you look for is they get a yin effect. They go kind of sleepy. You listen for a little gurgle in their stomach. That's the parasympathetics kicking in. And so there's a lot of things to do it. It's almost an art form in the lives that we live now to find ways of calming down. And I think we all need to find ways to do it.
Can I make a comment to that? I'm using some equipment. I've been trained the last probably 3 or 4 years. It's called NuCalm, N-U-C-A-L-M. It is binaural stimulation. Music that's set to specific frequencies to get you into the theta zone of sleep. So I use it for all my anxious patients. So it's non-drug relaxation system. In addition to the music, we block out the light with an eye mask or dark glasses. There's a small CNS stimulator that you don't feel. And it comes also with a cream with the, now I've been talking about all this chemistry and now I can't think of there are two, GABA and L-theanine, that's what I'm thinking of. Just to help get those neurons under control. So it was developed for PTSD patients and first used after the Oklahoma bombings, and I think it's been used in the medical world and dental world probably for the last 10 years, and just was brought into Canada. I'm using it now, but it was brought into Canada about 3 years ago. But for all my anxious patients and my TMD patients, to get them to relax, get the muscles relaxed, get the brain relaxed. So some of the patients do fall asleep and others just get into that pre-stage sleep. But I know the company is also using it for cancer patients, chemo patients, also for elite athletes and for people that travel.
I can suggest a really, really simple, cheap way of doing that.
Okay. Meditation?
Well, oh yeah, that's certainly important. There is if you get a couple of tennis balls and tie them into put them into a sock and tie a little knot on them, and you have your patient lie supine, have them rest the back of their head, just the occipital area where the cerebellum is, have it rest on the tennis balls for 5-10 minutes. They just calm right down.
And block out the light too?
Well, yeah, all those other things too. But it's a very a poor man's way of doing an expensive osteopathic manipulation called a CV4, where you compress the occipital bones, and they go into a yin state from it.
Okay, thank you.
I would place this question to anyone here, but also offer it in the form of information on the vitamin C. We've been all over the gambit on getting IVC also, all the way from hard to get, changing McGuff. You know, they went to $75, $80 a bottle. So we started looking for compounded C, beet, tapioca, corn, that sort of thing. Recently, we have gone back to McGuff, and they have the FDA-approved vitamin C now. Now, we all know we love that label, right? We've all been waiting for that one. But it is an FDA-approved vitamin C, supposedly. We contacted them because we had a very sensitive patient that was very, very sensitive, and so we were really trying to find out what it was. 4 or 5 calls and 4 or 5 levels of transfer to get to it. And what trying to see what their source was. Basically, they said that they used 3 sources. They wouldn't really tell what it is, but it's got to be beet, corn, or tapioca generally. But they said that no trace of the original source still remains in the vitamin C. So they can't say. So they have removed the source but retained the C. Now, we can call BS on that or whatever that they say. I'm just saying what they told us when we're talking about sensitivities and things like that. So I would ask anybody that knows more chemistry on IV vitamin C than I do, or if y'all had heard that. But that was just within the last week or so that that information was told. So they're pretty tight-lipped on it. I don't know why, but it seems like they would have to give you the source. So there you have it. Any comments? I would like to learn more myself.
Well, this is kind of following what you're saying about sympathetic, parasympathetic. Maybe it relates to stress, but we have a little thing coming down the pike at us in America called 5G, the small cell infrastructure that's being built out. And it's going to allow the Internet of Everything to take over our lives. I guess it's called the Internet of Things, but we might call it the Internet of Everything. Everything's got to be on the Internet at 28 gigahertz to carry a huge, vast amount of information in the microwaves. And, you know, some people don't do well when they're in that microwave environment, but everything has to be on the Internet. We'll have driverless cars coming at us, and they're going to be seeing their way around using radar. And so we're going to have, it's like the microwaving of everything, I think is what's emerging. And the next 60 days in America will be crucial for stopping federal legislation that will preempt the states and the local governments from being able to stop it, you know, regulating it. So it's coming down the pike. I encourage everybody to look at it, 5G and the Internet of Everything, because there are some who say it will be the most harmful thing that has come along affecting our lives. You know, burning skin, it won't go as deeply maybe under the body, but causing skin pain and a lot of eye damage from what I understand. So the EMF activists, scientists, doctors, some of them are up in arms about it, and maybe some of you are aware of it, have comments on it. Thank you.
Yeah, I'm no expert in it, but Magda Havas, perhaps you know of her. She's in our neighborhood, and I know her reasonably well. And they're starting a 5G project in our county, and in Canada, our county. They're putting this in, and there are people out trying to wake up the authorities about it. But the fact of the matter is that in Canada and the US, we have no regulation of electromagnetic frequencies. There's a total lack of regulation. As in comparison to Europe, where there's the regulations become tighter the farther east you go. Russia has much, much tighter regulations, and the tightest regulations in the world are in Kazakhstan. And the Russians, they know they have a lot more interest in biophysics than we do in the West. We've sort of invested in the chemistry more, and they've gone more to the physics. And they're quite aware of it. So that in Russia, for example, public health, if a doctor is identifying there's a problem of electromagnetic radiation in somebody's home, they will go to the house and do an inspection. Here, if you want that done, you have to find a private individual, and it's usually quite expensive. But it's a huge field. That's only the most recent thing that's come around. I see a certain number of these patients in my practice. I have one lady, she's about 50, and she is so sensitive she can feel police radar, and she can't drive a car that is newer than the last 5 or 6 years because of the computers in the cars. So she's extremely sensitive. And we were talking about this morning that she's one of the sort of canary in the coal mine. In her, it's very obvious. For the rest of us, it's not that obvious, but it is affecting us. And getting back to the question of getting our sympathetics down, Wi-Fi is in the home. That's another thing to turn down. Magda Havas has done the work that shows in the schools there's terrible pollution there. And she did a study in Toronto and repeated in Minnesota, looking at the mental and emotional health of students and teachers in a school, getting a good baseline, then coming back and cleaning up the radiation in the school, putting filters in the circuits and turning off the Wi-Fi's and all that kind of thing. They reassessed in a couple of weeks, and health went up, absenteeism went down, all kinds of really, really good measurements. And then a couple of weekends later, they turned it all back on again without telling anybody, and all the health problems came back. So families that are aware of that, there are many, many families and again, kids are affected differently. Some kids get really, really messed up. And those are the parents that go to the school board and demand changes. But the higher they go up in terms of authority, the more resistance there is. And yeah, it's a huge problem we have. And it's very much below the surface because most of us don't feel it, or we think we don't feel it. So.
Did you name that study, just so we can look it up? Do you know the name of the study with the school?
Just look up Magda Havas, Magda, Havas, Havas. She's a professor at Trent University. She's well published. She's probably the world authority on the subject. Pardon me?
Very bad.
Same kind of problem. Yeah, there's some people made very sick. Other people, they have it, they don't maybe realize it, but it's probably affecting everybody.
I just want to add two resources. Martha Waters at NIOSH is a specialist in electromagnetic fields, and she's published quite a bit, and she's a good resource for you to look up. The second one is actually the country of England, which is currently putting in legislation to reduce the use of cell phones in children. And they have a body of literature. Isn't that nice? So you can look up on their website the justification for legislation, which is really quite pronounced. These are two things that I'm most aware of. In the United States, we're absolutely horrible as far as identifying methods of control. And as a hygienist, you know, I'm even worried about people who fly airplanes. So